Welcome everyone to our 2022 Frederick P. Lee Memorial Lecture. The Frederick P. Lee Lecture was established in 2010 by Dr. Judy Garber and Dr. Miles Brown in honor of Dr. Lee, who headed Dana-Farber's Division of Cancer Epidemiology and Control from 1991 to 2008. Thank you to Dr. Garber and Dr. Brown for bringing the latest insights and perspectives regarding cancer research to Dana-Farber and honoring Dr. Lee in this way. Thank you to Dr. Lee's family for being here today. The Frederick P. Lee Lecture is given every year at the Dana-Farber Cancer Institute by an investigator who embodies the very high ideals Dr. Lee endorsed throughout his long career as a cancer epidemiologist, cancer geneticist before there were cancer geneticists, cancer survivorship researcher before that was a field, medical oncologist, population scientist, and mentor. We are pleased to pay tribute to Dr. Lee's vision and his very collaborative and rigorous approach to cancer research by inviting an individual who would have met Dr. Lee's approval for their contributions to the field in which he made his marks. This year, we are honored to have Dr. Gareth Evans, though still remotely. Dr. Evans is an internationally recognized cancer geneticist and epidemiologist who works in breast cancer, Li-Fraumeni syndrome, breast cancer risk and prevention. He has over 1,000 publications, 920 of which are peer-reviewed manuscripts, on which he was first or senior author of 330. His thoughtful and insightful work has changed our understanding of cancer genetics and the care of our patients, as you will hear in his Frederick P. Lee Lecture entitled From Syndromology to Population Cancer Risk Stratification, A Life's Journey in Cancer Genetics. Please join me in welcoming Professor Evans.
Thank you very much, Dr. Rana. That's a very nice introduction, and it's a pleasure to be giving this talk. I wished I was in my favorite US city, but at least I'm giving the talk to my favorite US city, and I even like tea. So what I'm going to do is take you through my journey from the start of leaving pediatrics in 1990 and doing medical genetics through until the present day. And as I will show you, 1990 was a pretty spectacular year for cancer genetics. So I literally took up a post as a clinical research fellow in Manchester at the very beginning of 1990. And my remit was threefold: to undertake a research thesis on a cancer-related subject, to set up a hereditary cancer services in Northwest England. There weren't really cancer genetic services in 1990, but there was huge burgeoning demand for cancer genetics. And also to expand the genetic register that we had set up there to include inherited cancer predisposition syndromes. And my options research in that first stage was to expand on Peter Farnden's work on Gorlin syndrome, or to undertake a clinical, molecular, and epidemiological study of two. And I chose the latter, but I'm going to give you a bit of a story of what I did in Gorlin syndrome as well, otherwise known as nevoid basal cell carcinoma syndrome. So this is interesting to see all these cancer predisposing syndromes here. If you look at 1990, quite a few of these had chromosomal locations, but very few of them were cloned. And in fact, NF1 was only cloned in 1990. The rest of these did not yet have a cloned gene. And in just 4 years, you can see how many genes were identified. A really phenomenal period in cancer genetics. All of these genes being identified and cloned in such a short period of time, and all of these extra chromosomal locations found. So just to point out these huge impacts, BRCA1 was linked to chromosome 17q. TP53 was identified by David Malkin as the cause of Li-Fraumeni syndrome, and the NF1 gene was cloned. So 3 pretty impactful things that occurred in that year. And for those of you who are too young to remember that, going to the American Society of Human Genetics, there were always these really big, impactful. Cloning a gene then was such a big event, and it was just amazing to be there. It sort of brought the sort of prickles on your spine up. So I'm going to start with Gorlin syndrome because this is where the syndromology comes in. You can see here these very large heads here, this frontal bossing, these widely spaced eyes here, and that's the sort of feature. You see these quite pretty children, and they often end up with quite coarse features as they go into adulthood. And this is Peter Farndon up in the right-hand corner here. And this is the first epidemiological study that we published together in Journal of Medical Genetics. And in the same, well, in 1991, I published this neonate who had these multiple bifid ribs, and as a cause, as a way of identifying a family with Gorlin syndrome. And if you get a big prize if you can make the diagnosis on this X-ray. So there are 2 major criteria on this X-ray. This is lamellar fault calcification at the top. There's a jaw cyst here in the mandible, and there's actually a bifid vertebrae here. So 2 major, 1 minor. You only need 2 major to make a diagnosis of Gorlin syndrome. And I should have probably given you a warning before I showed you this slide. This is the most horrendous thing. If you irradiate in childhood someone with Gorlin syndrome with a PTCH1 mutation, they just develop huge numbers of basal cell carcinomas in the radiation field. And you can see here that the center of the spine is quite in places quite well preserved. It's in the peripheries of the radiation field that the BCCs really develop. And unfortunately, this poor chap died from a carcinomatous meningitis from this basal cell carcinoma that infiltrated his ear. So we were very lucky to have a children's tumor registry in Manchester. And I was able to assess 173 consecutive cases of medulloblastoma, reviewing skin, dental problems, family history, and X-rays, and was able to identify 3 cases of Gorlin syndrome from that series of 173. And we actually showed loss of the wild-type PTCH1 in one of these. Ironically, I'm going to tell you that 2 of these cases actually ended up not having Gorlin syndrome. That's why only 2 of these cases did not have a mutation in PTCH1, and that's why only 1 out of 3 showed evidence of it. So the evidence from that was that at least 2% of medulloblastoma cases have Gorlin syndrome, and if they're under 2 years and desmoplastic, the risk was over 10%. So these are the diagnostic criteria that we published in 1993. You can see the major criteria here and the minor criteria. Importantly, you don't want things like medulloblastoma as a major criteria, because if you have medulloblastoma and you irradiate, you then get 2 or more basal cell carcinomas and they get a diagnosis. So that's one of the reasons medulloblastoma is not in the major criterion. So the PTCH1 gene is the major gene for Gorlin syndrome, was identified on chromosome 9, simultaneously by 2 groups, although I believe the Australian group were really there first. It is notable that the mutations occur throughout the gene. There was no clear genotype correlation published early on, although we have found a little bit of one since then. And when we started out looking at this, certainly by about 2012, we'd looked at about 171 people with Gorlin syndrome and only found a point mutation in 56%. But when we added in MLPA for copy number variants and RNA analysis, we increased that to 67%. That still meant there were 33% with no variant identified. And so there was a clue here that a second gene might be SUFU in the pathway, and children with SUFU have a high risk of developing desmoplastic medullos in the first couple of years of life. And in fact, we were able to identify mutations in SUFU in 3 out of 3 of our families, which had a single case of medullo and weren't due to PTCH1. And this is our publication in JCO from 2014. So 3 out of the 23 families that were PTCH1 negative, we found a SUFU variant. You can see here, we found a nonsense variant here. We found a missense variant that actually segregated extremely well within that family and is strongly predicted. We need to probably go back at that and look with ACMG criteria whether it would count now, but certainly loss of heterozygosity in the tumors as well. And then a CNV here taking out the last part of the gene in family 3. Clinical features, just to show that all of these patients met Gorlin syndrome criteria. So this is, there are patients with SUFU variants that don't necessarily meet Gorlin syndrome criteria, but in these 3 families, they all did. Notably, 3 ovarian fibromas here, a typical feature of patch 1 Gorlin syndrome. And we know that actually the risk of ovarian fibroma is actually higher with SUFU than with than PTCH1. You can see here a number of meningiomas as well. The one thing we didn't see was jaw cysts. So just to show you that these genes, and this is a story going through the early part of this talk, that you do get other syndromes caused by these cancer predisposing genes, and recessive SUFU mutations can cause a rare syndrome called Joubert syndrome. And so this is the genotype phenotype that we were able to publish in 2017, that the SUFU families, no one had jaw cysts, but the risk of medullo was substantially higher in SUFU than in PTCH1 Gorlin syndrome. So probably a 15 to 20% risk of childhood medullo with SUFU, but only around a 1 to 2% risk with PTCH1. So that completely rewrote the paper that I eventually published showing a 5%, potentially 5% risk with Gorlin syndrome. And so this sort of summarizes those things in that 2017 paper. So that's the first talk on Gorlin syndrome. I now move on to what I actually did my thesis on, which was NF2. There had been no previous large clinical study of NF2. It is a misnomer. We shouldn't be calling it NF2 because you don't get neurofibromas in NF2, and that's largely due to a very famous American neurosurgeon called Harvey Cushing, who stated that you got bilateral nervus acousticus tumors in von Recklinghausen disease. And he was such a strong character that no one dared to say he was wrong. And it took many, many years to untangle NF1 from NF2. So in that 2.5-year period, I went around the UK collecting families with NF2. I saw 110 NF2 patients in a 24-month period, obtained blood for DNA and cytogenetics. At the time, the gene wasn't identified, and we got very close to cloning it. We actually had a translocation in a tumor, but the tumor cell line died before we could clone the endpoints. And that work has shown that, these conditions are very different, NF1 and NF2. They do both have these very high de novo mutation rates, but NF2 may not be clinically recognizable until well into adult life. And then really there are minimal skin manifestations, although you do get some tumors in the skin. They are very different on the whole to the ones you get in NF1. And these were the diagnostic criteria that the NIH created in the sort of black here, the black text. And I added in 1992 to create the Manchester criteria, these green things here. So basically, you could not get a diagnosis of NF2 in before 1992 if you had no family history, unless you had bilateral vestibular schwannomas. And only about 85% of patients, de novo patients, will actually present with bilateral vestibular schwannomas. So they present either with other tumors, or they may have no vestibular schwannomas, or they may present with a single vestibular schwannoma and then other features. But the important other feature is multiple meningiomas. So where you get multiple meningiomas and schwannomas, it's much more likely to be NF2 than anything else. But these tumors on the hearing and balance nerve, these benign nerve sheath tumors, are the hallmark of the condition. And there are some very mild cases who that is all they get in their entire lifetime. You can see these tumors that fill this space called the cerebellopontine angle, and the main effect of that is loss of balance. But the thing people recognize is the hearing loss. And of course, when they get very big, they can cause substantial other problems as well. So having this genetic register meant that we could, due to cascading and family studying, get a very high level of ascertainment for genetic conditions in the Northwest. And we had genetic registers for NF1, NF2. We added von Hippel-Lindau, familial polyposis, and Gorlin syndrome. And by 2008, we had over 3,000 families registered with cancer genetic conditions. You can see of those conditions here from 90 to 95 that actually tumor predisposing syndromes made up the majority of the registered conditions, with the those in the darker blue here. And we also had a really good tumor registry, cancer registry, that started in 1960 that allowed us to really get very high levels of ascertainment. And we've been able to publish incidence and prevalence figures. One of my highest cited papers is our birth incidence and prevalence rates for these genes, NF1, NF2, von Hippel, FAP, and Gorlin syndrome. You can see here the number of studies. We've done a number of studies on NF2, but also on these other conditions. And you can see the 2009 paper here with lots of citations, the number of living affected cases. NF1, we got a birth incidence of 1 in 2,700, and NF2, 1 in 33,000. And you can see the prevalence is a bit lower, and that's because these conditions do not give full life expectancy. Apart from Gorlin syndrome is close to full life expectancy, but they don't get diagnosed necessarily until adulthood. So one of the quandaries that we found early on with NF2 was that the detection rate in blood was 96% in the second generation. But in the first generation, there was really quite a low detection rate. Only about 50% of de novo cases with bilateral vestibular schwannoma, we were able to identify a pathogenic variant in blood, and that there appeared to be low transmission rates, particularly in those with older onset disease. And we know that the NF2 gene has this very high de novo mutation rate. More than 50% do not have clinically affected parents, probably nearer 60%. And previously, the frequency of mosaicism had been reported to be between 25 and 33%. In fact, we published the first mosaic NF2 patient in 1995. And this is just to show that obviously the first cell doesn't have the genetic fault, but it may occur early in embryogenesis in a small cluster of cells or later on, and have this mosaic picture with a gene fault spread around the body or only affecting a segment. As you see here, this was our first publication in 1994. And then in the American Journal of Human Genetics, a larger series of mosaicism cases. And what we have been able to show is that the types of mutation are different. So the more severe mutations that cause more severe disease are much more likely to be found in the mosaic situation. You get these very highly significantly higher rates in the mosaics. 41.8% have nonsense mutations versus only 9.75% of those with the inherited type. And this goes through all of the cases. For instance, missense variants are the mildest variant, 9% of inherited cases, but only 2% of mosaic cases. And then when we studied the conditions, and this has been published very recently in Genetics in Medicine, we were able to show that even in those with bilateral vestibular schwannoma with no delay between the two schwannomas, only at least 50% of those were likely to be mosaic. Many of them proven, but the calculations were that that half of them would be mosaic. And as you go to the sort of more asymmetric presentations like unilateral vestibular schwannoma and other tumors, it gets even higher. And then on an age basis, if you go from bilateral vestibular schwannomas in a sporadic case presenting under 20, it's still a 20% rate of mosaicism, rising to over 80% in those who present with bilateral vestibular schwannomas over the age of 60. So NF2 is the highest rate mosaic condition that is out there in terms of tumor predisposing syndromes, higher than tuberous sclerosis and FAP and these other conditions. So you're getting on for 50% of all de novo cases are mosaic, many of them only identified by assessing 2 or more tumors. And so this is the mosaicism rate. When we look at Sanger, we're actually only picking up a small proportion, but where we look at NGS, we are now picking up around 39% of the mosaics on NGS, with sometimes as low as 0.51% allele frequency. So the next thing to come to is schwannomatosis. So schwannomatosis is an allied condition to NF2, where the genetic fault is not in the NF2 gene itself, but in one of 2 genes, although there are more than 2 now. DGCR8 is potentially a 3rd gene on chromosome 22, where the gene fault is in a separate gene, but you end up getting a mutation in the NF2 gene in the second on the same allele, and loss of the normal copy of the gene. So you get a 4-hit, 3 events that leads to the development of schwannomas. So the schwannomas are still driven through NF2 loss, but the primary driver is a germline variant in SMARTB1 or LZTR1. And these are the criteria for schwannomatosis that have evolved over time. There are new criteria which have are about to be published in Genetics in Medicine that I was heavily involved with at the moment. And you can see these three genes on chromosome 22, with LZTO1 being the most centromeric of the two, and when they were identified. And the key factor where we found big overlap is with LZTR1, because in the past it had been decided that vestibular schwannomas were actually an exclusion criteria, but we now know that that you actually do get vestibular schwannomas, although usually unilateral, with LZTR1. And in our initial paper, when we looked at LZTR1, we found a relatively high rate of mutations, both in familial and sporadic cases. That sporadic has now dropped down to about 9–10%. But we found 2 cases of unilateral vestibular schwannoma plus other schwannomas that carried a mutation in LZTR1. And that has now risen to, we've now got 9 families with a single case of a unilateral vestibular schwannoma plus other schwannomas. So one of the causes for concern in making a diagnosis without a molecular test. So the other key feature of NF2 is meningioma. And these are commoner tumors than vestibular schwannomas, again, benign tumors, but we include these tumors as oncological tumors because sometimes they are treated oncologically. And there is a rare type of tumor, a meningioma called a clear cell meningioma, that really wasn't recognized properly until around 10 years ago. And we know that that you can get multiple meningiomas, sometimes multiple meningiomas in childhood. And so we carried out exome analysis and found loss of function mutations in a gene called SMARCI1 in 2 of the 3 exomes that we carried out. Sanger sequencing of a further 6 cases found 2 more mutations. And so we found essentially a number of families where there was a loss of function mutation, where you got these clear cell meningiomas, predominantly in the spine, but we've now seen families where it also occurs in the head as well. And these are quite aggressive grade 2 meningiomas that have a high recurrence rate. And these are the exomes that we found published in Nature Genetics, as you see, in 2013. And this is the RNA analysis showing that the +2 canonical splicing variant was actually causing a truncated protein. And this is another family with a nonsense mutation and a frameshift deletion, making up the 4 families that we published initially. And some of these are de novo, but some of them are inherited. SMARCI1 actually, as opposed to LZTR1, is highly penetrant. And we've now found meningiomas that occurred quite quickly in people we thought were non-penetrant. So it is a condition that does need follow-up, even in the parents who appear to be not having any problems. And this is a case of a phenocopy where the mother had a cranial meningioma which was positive for SMARCI1 staining, whereas the daughter was negative, and the daughter had not inherited the gene fault from the mother with meningioma. And then finally, in this section, I'm going to talk about the analysis of young onset meningioma and schwannoma. Meningioma under the age of 25. We looked at all of these genes, NF2, SMARCI1, SMARCI1, SUFU, and this was the detection rate. 14% had SMARCI1 mutations, and that was really the main other cause of early onset isolated meningiomas apart from NF2. And when we removed the retrospectively diagnosed NF2 cases, it was about an even Steven between SMARCI1 and NF2 as to the inherited cause of these very early onset meningiomas. So you should certainly be testing isolated meningiomas under the age of 25 for both NF2 and SMARCI1, although if it's clearly not clear cell meningioma, you're very unlikely to find SMARCI1. And when we looked at isolated cranial schwannomas, again, we found 4 LZTR1 mutations in very early onset tumors. One of those was not a vestibular schwannoma, but again, a lot of NF2 mutations, but some of those were mosaic, again, this asymmetric presentation. So again, just showing you the overlap with some of these conditions. You can see Coffin-Siris syndrome here, dysmorphic condition where you're not getting loss of function, but potentially gain of function or recessive mutations in these genes in the same pathway. And then you've got LZTR1, of course, causing occasionally recessive and sometimes autosomal dominant Noonan syndrome. And then with SMARCI1, you've also got this bizarre fact that you get schwannomatosis in some people and this terrible condition, atypical teratoid rhabdoid tumor, these nasty, usually lethal tumors in early childhood. But the different types of variant you get, you can see the schwannomatosis mainly in the extremes of the gene, and they're usually hypomorphic mutations. Whereas the ATRTs are the CNVs here, lots of large whole gene deletions, but full truncating mutations, full loss of function mutations. And that's why in the schwannomas, you often see this sort of patchy staining, mosaic staining in the tumors, because there is some potentially partially functional protein there. So that's the end of my sort of dysmorphology into the syndromic conditions. So what about common cancer predisposition? Well, I joined the Family History Clinic with Tony Howell in 1990. We've now seen over 14,000 women with a family history of breast cancer, written a 33-year follow-up paper just recently, a number of papers on this series of women. And one of the first questions I asked myself was, what do women understand about risk? I mean, what do I understand about risk? But I hoped I knew, but I don't think men are that much better at understanding risk than women, but it was that concept of how well we're giving risks, how well is that risk understood? But a little thing about the referral pattern, you can see here this biphasic referral pattern and this huge number of women referred after the identification of the genes, and then this massive rise again. And I bet you can't guess why that is. Again, this is 2013 that this massive rise happened. And importantly, these were eligible referrals. So this wasn't the worried well necessarily. It was mainly eligible women for referral. And this we published showing this really big rise over the months from May 2013 compared to the previous year. And it's the Angelina Jolie effect. And really that effect has been very sustained, going on for 2 or 3 years after she came forward. We've had many, many more families coming forward. It really had a positive impact. As I said, it wasn't just the worried well, it was many women coming forward who really should have come forward. And these are the ages of entry. You can see here, mostly in the 30s and 40s. And the range of risks that we've given women, you can see here, obviously, some women being given population risk or below, but quite a high proportion of these women in the high risk category, above 30% lifetime risk. And this was the first paper I published on risk perception in 1993, showing that many women underestimated population risk. And in those days, it was 1 in 12. So only 8% in 1993, and many women overestimating the risk by as much as 100%. So many women, over 50%, having their risk perception either decreased or increased. And post-council, when we were able to feed back, Chris, actually, it was still not that impressive, but 33% gave the exact risk, far higher than originally. And actually, most women were within the range that you might think is acceptable. And importantly, 41% of women chose their own personal risk correctly, the one that we had given them. So although it's not perfect, a lot of women did take the general idea of their risk. And we do quote an odds ratio rather than a percentage. We feel that that is much better understood. So now going into sort of personalized screening, and we set up a study called PROCAS, Predicting the Risk of Cancer at Screening, in 2009, where we offered risk assessment using mammographic density and all the risk factors in a risk model called IBIS or Tyrer-Cuzick. And we also have done a big assessment in our family history clinic called FH Risk. And these are a lot of the risk factors that we know about. Breast density is the most important of these, and that's why we felt it was important to include that in our risk assessment in these studies. And now all women we see, we include mammographic density in their risk assessment. I don't need to probably tell many of you about the established risk factors. The ones that don't actually go in the models currently, although alcohol is in the CAN-RISK model, is exercise is not in there. BMI is quite a blunt instrument. Actually, its weight gain is a much better assessment of risk than BMI. It's weight gain from the age of early adult age. And obviously genetics comes in. And in 2009, we only had 5 or 6 SNPs. But really, it has burgeoned since then. We've got tests now for 313 SNPs, and some firms are actually offering SNPs of up to 1,000 SNPs, polygenic risk scores. The breast density clearly is a huge risk factor. You can see here these two breasts. If these were 40-year-olds, this woman here would have a 5 to 6-fold risk of the woman with a non-dense breast. And really, the question is, if we do population assessment, and really it's a continuum of risk, it's not just women at 10 to 12% lifetime risk and women at 80% lifetime risk with P53 and BRCA1. It's a whole continuum, like you see here, and you would offer different things at different levels of risk, maybe even reducing screening. And there are a number of studies, including the Wisdom study in California, a MyPeb study in Europe, that are actually doing decreased screening in those women who come out as low risk. And in the UK, we actually do 3-yearly screening. So one of the few countries in the world that does that, but we actually do additional screening based on NICE defined high risk. They get annual mammograms from 40 to 59. And we also do MRI screening annually in the national program in carriers. So there is risk stratification already. So these are the first 6 that we had available in 2009. And some of these have quite big factors. You can see here FGFR2, TOX3 as TNRC9 is now known, have reasonable odds ratios, and they're relatively common. So these are going to give quite a big effect as part of your polygenic risk score. So in 2022, we now know that these SNPs actually make up more of the inherited components of breast cancer than the moderate and high risk genes put together. And you can develop a polygenic risk score by multiplying the odds ratios around 1 in order to get a polygenic risk score. It's sometimes discussed as a Z-score, a log odds, but I think what we understand better is a polygenic risk score of 1.0, is the average risk. If it's below 1, it's a reduction in risk. If it's above 1, it's an increase. And these were some early studies from Cambridge showing that in a BRCA2 carrier, just the first 5 SNPs, sorry, the first 2 SNPs here, the 2 I mentioned, could give you quite a variation in your risk if you had none or all 4 risk alleles. And this was the first 6 SNPs here. Again, getting a risk variation from 95% if you've got all the bad ones down to only 40% in BRCA2 if you've got all the good ones. And just showing in the general population and those with a family history that the quintiles separate very nicely. You can see here in those without a family history that the bottom quintile never gets anywhere near the screening threshold if you set a threshold of a 10-year risk of just above 2%. So in the PROCAST study, as I said, we enrolled 58,000 women, 10,000 of those provided DNA samples. Initially, we looked at 18 SNPs found by Claire Turnbull in 2010 using ICOGS weightings from 2015. And this was how we were able to stretch the risk out from the Tyrer-Cuzick alone in the blue, getting very few women at high risk, that's 8% 10-year risk, and pretty much no one in the very low risk, less than 1% group. And you can see here that as you add in density and SNPs and all 3 together, you really do start to get people in these lower and higher categories. And we found that there was really very little overlap between the different things, between the polygenic risk score, density residual, Tyrer-Cuzick 10-year risk, and SNPs. And the PRS was really extremely well aligned to where you would expect it to be. So it wasn't over predicting at the top end, wasn't under predicting at the bottom end. And this is just showing you the best that we got with SNP 18. You can see here we were able to identify about 30% of the breast cancers in about 18% of the women at moderate or higher risk, and 30% of women at below average risk who only developed about 17% of the breast cancer. So does adding in more SNPs improve things? Yes, it does. We looked at SNP 143, that's published in International Journal of Cancer last year. Last year. And again, it really did improve the calibration of the score. And this is our current situation with 2,340 women in a case control study. And we were able to identify here 21% of the women that developed 40% of the cancers, 45% of the stage 2 cancers in this moderate and high risk group. And here, 18%, 1 in 6 women who only developed 7% of the breast cancers in the low, below average risk group, in the sort of actionable low average, so less than the risk of a 40-year-old in the next 10 years. And this is what we do generally in the population. Everyone is the same. And so it really begs the question that we should be doing something more intelligent about informing women of their risk. Most women do want to know if they're offered it, and it means we can target more frequent screening, preventive measures at those at increased risk, potentially reducing screening in those that aren't. And it is accurate. This is the actual incidence in the risk groups, and it is within the expected amount in the 10-year risk groups. Not only that, we were able to show that the low risk group had low risk cancers, many more grade 1 cancers and extremely good prognosis cancers, including low grade and moderate grade DCIS. And as you add in the SNPs, you get more and more women into this low risk category, but the ratio is actually improved between cases and controls. So less cases, more controls being identified. And at the top end, in the high risk category, you can see here that the SNP 143 improves again the number that you identified, 20% here of the cancers, nearly 9% of the controls here, but improving the odds ratios between cases and controls. And this is the sort of Maladat study showing how across all of these epidemiological studies, including PROCAS, including FH risk, you can see here that the odds ratios per standard deviation are pretty much identical. So it is extremely well calibrated across all of these. I will say this is white Europeans. We are working a fix around for people who are not white European, and it is a relatively simple fix. What about adding a gene panel? Well, we found 1.7% of controls, 1.7% of cases had a BRCA1 or 2 mutation, only 1.7%, and 5.7% had an actionable breast cancer gene. You can see here we had 4 PALB2, 9 BRCA1 and 2, 16 CHEK2 and ATM, and then 3 of these other genes here, surprisingly a TP53 in a relatively old individual here, and this is impressed with genetics in medicine. We've actually found most of these with mutations were already in the higher risk categories. So many of them were already above average, but obviously a number of them did switch category as a result of finding a fault in one of the genes. But importantly, on a population basis, you can see here, this is SNP 313 plus a panel. We're not really identifying anything substantially different. It's the adding in more SNPs that really gets you lots more people in this low risk category. And the same is true in the high risk category, that actually in moderate and high risk, adding in a panel doesn't really identify you that many more. It's incredibly important for those women where you find it, but on a population basis, genes are not as important as a polygenic risk score. So obviously other conditions I'm not going to touch on, but there is more we can do across a whole range of conditions. So it makes sense that if we're doing polygenic risk scores, why not do it across a whole range of conditions? And even in the FH risk controls, we only found a relatively low rate of those positive for BRCA1, 2, ATM, CHEK2 of around 4% of those who had not previously had BRCA testing in their families. So this had siphoned off those that were in the higher risk elements. So in terms of population testing, there is a low detection rate in breast cancer. And obviously this is an older population, but really it is exaggerated in so many publications, the proportion of breast cancers that actually have BRCA1 and 2 outside founder populations. And it really is below 3%, closer to 2% in whole populations when you're not using age as a cutoff. But what about very early onset? Now, this is where genes are incredibly important. Just to show you, this is under the age of 30 or 30 and under. P53 is more important than BRCA1 and BRCA2. And you get actually a reduction in the rate of BRCA1 and BRCA2 under the age of 25. So up until that 25 to 30, where the rates go right up, it then drops off, a bit like ovarian cancer where it drops off under 30. But under 25, TP53 is the most important gene. I seem to have lost my ability to go forward. And these are the other genes that we identified. PALB2, only 3. So all of these other genes below 1%, whereas actually we were finding nearly 6% P53, nearly 10% BRCA2, nearly 20% BRCA1. And the case control data showing very nicely, hugely significant scores for P53, BRCA2, BRCA1, and that's published just recently in JMed Genet. But importantly, the risk of a second breast cancer really quite higher for TP53 than BRCA1 and BRCA2, again, published in Cancers last year. And we were the first to publish a birth incidence for TP53 at around 1 in 5,000. There are a couple of publications by the NIH group suggesting it could be as high as 1 in 500, but I think they now accept that that is only with a very loose categorization of variants, and some of these variants that came out as possibly pathogenic may even be protective. They may even be a gain of function P53 variants. And you do get mosaicism in P53. We have 5 cases now. You can see the variant allele frequency here. They develop typical tumors, sarcomas, MPLST being a sarcoma, and Leiomar sarcoma. So just to bring it back, and I have done it between 50 and 55 minutes. This is Li-Fraumeni syndrome. So I brought you back to Li-Fraumeni syndrome with a TP53 mutations with BRCA, with breast cancer, particularly this very early onset breast cancer. And just to leave you with the sort of ultimate high risk gene being P53, but the SNPs here really now coming into their own as well. So I believe that risk stratified screening is pretty much there now for implementation if we have the will and the finances to do it. But SNPs are really, really important in being able to do that stratification. And many, many people to acknowledge. I'll leave that slide up while someone asks me some questions, if any has any questions. Thank you.
Thank you for a wonderful talk, Dr. Evans. That was really just beautiful. I'll ask the first question, which is related to TP53 mosaicism. And it's something that obviously we experience in our clinic as well. Through NGS testing, we identify individuals who are likely to have these mosaic TP53 variants. How do you manage them? Do you follow them with sort of classic Li-Fraumeni screening recommendations?
Well, the first thing I would do if I found a mosaic variant in blood, so a low allele frequency in blood, is check it's really a mosaic variant. So you have to test it in another tissue to show that it is not just clonal hematopoiesis. So you would really suspect clonal hematopoiesis in an older patient, a smoker, someone who's had radiotherapy or chemotherapy. So you would need to ideally test the tumor and check that it's in the tumor, but also you can test, fibroblasts or a hair follicle or something else, another tissue that doesn't contain lymphocytes. But yes, we would include them. And in fact, if I go back in the talk, you can see here that this girl with an adrenocortical cancer developed a spindle cell sarcoma at 28. So they are getting second primaries. So, so certainly if you're picking them up in this younger age group, I would absolutely follow them up with whole body MRIs. And potentially, if you do the Toronto protocol, we don't do the full Toronto protocol in Europe, but I would definitely follow them up with enhanced screening.
Thank you, Dr. Evans. Just another question. It just came through in the chat. And the question is about how your institute is using SNP testing in clinical practice. What target populations do you focus on?
So we have actually, I hadn't got time to go through all of that in this talk. We have just completed a study where we've offered this in the general screening population when women come for their mammograms. The PROCAST study, we didn't give the results until quite far in, but we actually, within 6 weeks, gave back risk information, including SNPs, including mammographic density, and we got the highest uptake in the high-risk group that we've ever had for chemo prevention. So 70% of women decided when they got their risk feedback that they would go on to anastrozole or tamoxifen. So we were incredibly surprised. We were expecting maybe 20%. We, in the past, have only got around 10%. But women who are newly identified without realizing that they're high risk, that's the time that they're most likely to uptake chemo prevention. So yes, we are using it. It's not yet been adopted by the National Health Service, but there are very strong moves within the UK that polygenic risk scores should be implemented. And I guess we still just need a little bit more research, but in terms of their applicability, it's quite clear you can apply these polygenic risk scores in risk models, and they are highly predictive of who is going to get breast cancer and who isn't. And they are highly predictive in a number of other cancers.
Thank you. That's wonderful. Those rates of chemo prevention are sort of mind-blowing compared to what we usually see in our clinics. I think this is the
But I think
answer.
It's because women get used to being at risk. And it's when they're surprised that suddenly they didn't know they were at increased risk, and suddenly, they might have a very limited family history, but high breast density and a bad polygenic risk score, and it shoves their risk right up. And then suddenly they're presented with a high risk, and when they're given the option, they go for it.
Thank you so much. That's really a wonderful point. Dr. I think Diller has a question. Do polygenic risk scores impact upon risk of breast cancer or other cancers in the setting of Li-Fraumeni syndrome or germline TP53?
Yeah, I don't think we've got enough data really on that. I mean, we know that it impacts on risk extremely well in ATM and CHEK2, the moderate risk genes. We know that it does to a lesser extent in BRCA1. BRCA2, it still has a pretty big effect. P53, I just don't think we have the data yet. It's certainly worth a look to see if, but I think we would need to, we'd need to go across probably a number of centers in order to get enough cases and controls together. And the concern would be that you would need to make sure that you're controlling for the type of TP53 mutation. The dominant negatives obviously giving a higher risk. So you can't just necessarily lump them all in together. So I don't know, it may well be that they have an effect. Whether that's enough to change a woman's mind about what she does about breast cancer, I'm not sure. I think it is enough in BRCA2. I don't think it'll be enough in P53.
Thank you. Dr. Diller has a follow-up question, which is, would it make sense to look in childhood cancers?
What, for polygenic?
For polygenic risks that would impact childhood cancer?
I mean, yeah. I think you'd start off looking in sarcomas to see if there were population sarcomas, to see if there were SNPs that you could associate with risk. And then if you identified them in childhood sarcomas, not showing a good effect in terms of building a polygenic risk scores, it might then be something that you could see if you could apply to Li-Fraumeni. But I would start with the childhood sporadic tumors rather than leaping straight into TP53 to see if you can find them. I just don't think you'd ever get the size of study necessary to do a GWAS. You'd really need to start with at least 1,000 childhood sarcomas. And I don't think anyone is going to be able to collect 1,000 Li-Fraumeni sarcomas in order to do that.
Thank you, Dr. Evans. One last question from Dr. Vichkovsky. How do you think cfDNA, cell-free DNA, will be incorporated into screening for patients with germline pathogenic variants? Do you think there will be more of a role for this with certain genes as opposed to others?
Yeah, I mean, I think there will be a role for it. Obviously, I think the thing with P53 is that actually, although you've obviously got one variant that's already there, what we see when we look in TP53 tumors is often we see lots of other mutations within the tumor. Often, I mean, in our childhood ACC series, we often saw 4 or 5 additional mutations. So I think looking for second hits in the blood in cell-free DNA might be a way of early detection or enhancing early detection in Li-Fraumeni syndrome, for instance. In BRCA1 and BRCA2, the predominant second hit is loss of heterozygosity. So I don't know whether actually, again, TP53, the vast majority of high-grade sarcoma, high-grade serous tumors, the vast majority of triple-negative breast cancers will have a TP53 mutation. So it might be TP53 would be a good cfDNA test in BRCA1, but we need more data in order to know that that's the case. But absolutely, I think there is a case for looking. And you know, if you're taking blood for other reasons, why not look at cell-free DNA and see if you are able, in those that have early cancers, to pick up a signal in blood.
Thank you. Thank you, Dr. Evans, for that answer. And thank you so much for your wonderful lecture.
No problem. Thank you. It's a pleasure.